So last week we went over soft tissue techniques for the shoulder joint complex. All right. Two physical therapists working together. I just came to your clinic. Right. Instruct me in performing a special test to assess the functional range of motion of both of my shoulder joint complexes.
You could do the painful arc sign would be one. So what I'll have you do is if you can stand up and face the wall, what you're gonna do is you're gonna bring your arms out and then you feel any pain during anywhere within that range of motion, that would indicate some pain within your shoulders. Do you feel any pain anywhere like within the range?
No.
That would be one is if you did feel pain, that would be like indicative of one, so it was like a labral pathology or so within the shoulder.
If I felt pain, where within that motion?
It's about around like 70 to about like 110 or 70 to about like 120.
So if I felt pain or discomfort or between 70 to 110, so I'm gonna go right here to right there, what would that be a strong indicator of? What type of pathology?
I remember in common, I believe it was dealing with labral pathology.
What if I experienced pain and I got to about one, say I got to about right here. So I got to about one, say I got to about right here, and I said, oh man, I experienced the pain from here to here, here to here. That's where the pain is. But right up in here, there's no pain. I don't experience any pain from here to here. But when I get here to the end, that's when I experience the pain. Which one is more rotator cuff? What degree of range of motion would you suspect supraspinatus? If I say it was painful, at what degrees would it likely be more painful? So say if I had supraspinatus tendinitis, all right, or some type of supraspinatus tendinopathy, which range is it going to present itself? Say the pain is within 70 to 110 degrees.
That would be about around the supraspinatus muscle would be within pain and around there within that case.
Okay, so I'm gonna take y'all to figure out my source of pain, right? So now, who can remember what is the likely cause of the pain if the pain presents itself anywhere between 150 to 180 degrees of range of motion? AC joint involvement, AC joint arthritis. That's what you think is some type of arthritic formation. This is standard textbook, but this presents itself in the clinic because I see patients that present with it all of the time. I got one on my caseload right now. She said she's willing to come to the class. She's a hallmark case. Okay, all right. Now, so you did the painful arc test. Okay, what functional can you all do to assess my functional motion or functional mobility of my shoulder joint complex? What is it? The Apples. Yes. Run me through the Apples.
Okay, reach behind your head. I just got you do that. Anything you got?
No pain, but I do feel some tightness.
Okay.
You gotta come look to see what my hand is, because you gotta do both.
Okay. Can you go down any further?
As far as I can go down.
All right. Let's try the other side. Can you go any further than that?
As far as I can go.
Okay.
Which one went further?
This one.
All right. You gotta notate that, because y'all about to treat me too.
Okay.
I'm about to show y'all what the practical is like.
And then can you reach behind your back? Kind of like. Okay.
As far as I can go.
You can't go up any further?
That's it.
All right, let's try the other side. Look at that. You got better range on the left side again. Then one more. Can you touch your right hand? Can you touch your right shoulder with your left hand? Oh, wait, turn around. Okay, then you do it with him. Do it one more time. Each side.
No problems with that.
No. Alrighty.
But I did feel marked tightness. Although I went further with them, both of them I felt tight.
Mm-hmm.
So which one's more restricted?
Your right side.
All right, what soft tissue you gonna do? What joint mobile you gonna do? What therapeutic exercises you gonna tell me to do? Let's go. And you gotta be able to rationale it out. And treat me, I'm the patient. You two about to treat me right now.
Subscapularis release. Yeah, for the soft tissue.
Why are you gonna do subscapularis release?
Because that helps like to strengthen it, both depending on which way, if it's weak, depending on if it's weak eccentrically or concentrically, that can help strengthen out the muscle and help like cause it to get looser to be able to go through more range of motion.
So let's go back through. So that's your second line of thought.
Yes.
That's gonna be your second line of thought. I'm hoping everybody paying attention. I'm not doing this in vain. Because I'm gonna be very tough on this practical. I'm not doing this in vain. So that'll be your second line of thought. If I'm limited internal rotation, what's gonna be your first line of thought as soft tissue that's limited in that?
Oh, would it be the muscles that are more?
Don't tell me the muscles that are more, tell me the name of the muscle. This is how it's gonna be on the practical. Tell me the name of the muscle.
It's tight in internal rotation. So the muscle's like tight. It's like it makes contracted, if that makes sense.
So it's an antagonist muscle to internal rotation,
well,
right?
yeah.
That's what I wanna hear you say.
Okay, yeah.
It's an antagonist muscle to internal rotation. So if it's tight, it's gonna limit internal rotation.
Mm-hmm.
All right? That's your first line of thought. All right, you could do that, your second line of thought. So if you say subscapularis as your second line of thought, you must, if y'all come and go second line of thought, you gotta be able to explain it very well in order not to fail your practical. You gotta know how to explain that second line of thought very well. Okay? So you could say that the subscapularis is weak and taut. All right, I'm gonna consider it a taut muscle and weak muscle, also limiting internal rotation. Then you can address that and also work on it conceptually. But I'm gonna be very tough on making sure you verbalize it correctly. So let's go with your first line of thought. Let's go with the first school of thought. First school of thought, checking the antagonistic muscle. All right. So now you gotta treat me. Y'all just treat me. First line of thought, she said infraspinatus muscle, right? So let's go. Let's treat me.
Okay. Well, are we starting from the very beginning?
Soft tissue. What are you gonna do?
I was gonna do like an anterior thigh.
Do that after the soft tissue.
Okay.
Because we're going in the order of the rubric.
Okay.
You're gonna address soft tissues first.
Gotta lay on your back.
Okay. I'm gonna lie on my back.
So contact the lower border of the scapula. So 80 up.
Feel where he's tight?
Yeah.
Okay.
It's like
So
you
do
know,
you feel like you can control him to hold him and to stretch that? If you do, then you're good. If not, you can use a towel or a pillow between there as well to support.
Okay.
That
Like
looks
this?
good.
Okay. So for 10 seconds, and then can I do like 3 sets of 10 seconds or?
Go ahead and do about 6 or 10 seconds.
Okay.
That's 6 reps. You're treating me. You wanna get an outcome because you're gonna retest me. Make sure you hold that horizontal adduction. There we go.
in the gym.
Yes,
Don't
you-
shake
you
it.
gotta be in the gym. Physical therapist gotta stay fit.
Okay.
Dr. Carter, during the practical, how long would you give us to do the whole entire thing?
Probably about 10 minutes.
Okay.
You should be able to knock it out in 10 minutes. When you get your patients in the clinic, they're gonna expect you to do examination and trial treatment in 60 minutes or less. To be productive. That's if you don't want the business to go out of business.
A little bit. Make sure you block the scapula first.
Mhm.
Once you feel like
Yeah.
you've got it, then take it till you feel it wanna move. When you feel it wanna move, that's where that's the
Mhm.
spot.
That's the spot.
Okay? Feel it wanna pop into your hand. Blocking. Oh, there it wants to move. Okay.
There you go.
That's it. And then stretch from there.
All right. Now, so we're gonna consider that's the soft tissue. You did some soft tissue work, okay? Because you stretched the soft tissue. So that's your soft tissue intervention. What joint mold were you two gonna do? Liz, you do the joint mold. Y'all discuss what joint mold you're gonna do.
Okay. I think you should-
So I just asked them, they're supposed to be working on the joint mold that they're gonna perform now. The movement that they're trying to get me to improve is right shoulder internal rotation, functionally. So they just stretched the infraspinatus muscle,
Yeah.
which is an external rotator, but it would limit me in internal rotation if it is taut. So this is the first line of thought of treatment. So they stretch my infraspinatus muscle. Now they have to perform a joint mold that is gonna help improve the motion that I'm restricted in, which is internal rotation. So which joint mold are they gonna do? Let's go.
Okay.
This is the practical. This is, I'm basically mimicking the practical verbatim.
I'm gonna do the one where your arm is going across, and you put your hand on your towel, forming to stabilize your scapula.
I don't think this is your position.
Oh, this is your line of force right here.
Yes.
So I can get more range of motion.
Lies the scalpel with your hand.
So you're stabilizing the scapula and you're moving what? When you moving on what?
Supposed to, feel like a more head moving on the glenoid.
Go.
Mhm.
Neural head posterior, glenoid fossa.
What is this glide necessary for?
No, it's for internal rotation, shoulder flexion, and shoulder abduction. More, I think, like coronally. And I'm trying to think, because it was 4 of them. I'm trying not to look at my thing, but I know flexion, internal rotation, and coronal abduction. I think also horizontal abduction
Or the horizontal adduction?
or adduction.
Because abduction is
Oh,
gonna
yeah,
go
the-
interior.
Yeah, it does say adduction.
Line of force, get on over there.
Yeah.
There we go.
Elbow all the way to his shoulder. You see that? It's like one continuous line. That's how you wanna be with this technique. Can y'all see that?
So if you want to make me work my infraspinatus eccentrically,
Yeah.
what would you have me to do?
I would have you go, or like,
See this?
slowly and.
So
and
this is
rotate.
all muscle action. This goes back to gross anatomy. So you all gotta have a command of your muscle action. This goes muscle action, therapeutic exercise. Therapeutic exercise, you get what the muscle contracting concentrically, eccentrically.
Okay.
So
let's
now you
do-
wanna do something,
Yeah.
not, I want y'all to follow me. So now, we wanna elongate my infraspinatus, right? We wanna elongate that muscle. What you gonna have me to do?
I'm gonna rotate to elongate infraspinatus, which is external rotator. So we're gonna do interrotation.
There we go. So now
Yeah.
you got me eccentrically strengthening. And I bring it back to neutral.
Right.
How many sets you want me to do?
3 sets of 10.
3 sets of 10.
Or a 10-second hold.
I'm not gonna hold
Or
it
maybe
that
like
long.
do like 5.
I'm just gonna do
4.
3 sets of
Okay.
10. More slowly. Now, I'm doing right shoulder. So she has me supine, doing right shoulder internal rotation with 5-pound dumbbells. What is your why behind this?
It eccentrically strengthens the infraspinatus.
Okay, good. So she said that she has me eccentrically strengthening
That was good. You wanna say
the
side or you okay?
infraspinatus. So that's good. So she was eccentrically strengthening my infraspinatus, which also had my infraspinatus elongating, right? That's good, because I was limited with internal rotation, so it needed to be elongated. But she came back and strengthened it eccentrically, which it probably needs that. Now, you're gonna reassess. All right, what did you have me do?
Let's do, well, let's look down and do first.
We're just gonna look at the right one, because we're gonna treat the right one.
Okay,
So you gotta try to visualize where it was when we first started, and visualize how far I can go now.
all right.
Feel like I got a little bit more.
Just a little bit.
Just a little bit. Yeah, just a little bit.
You reach behind your head.
Look behind my head.
That's a little bit slow. Still, it's a little, still tight.
Mhm.
Yeah.
But I don't feel as tight as I felt before.
Okay.
So the treatment was effective.
Okay.
But it takes consecutive, and you let your patient know, hey, this is our regimen. We're gonna stick with this and some other things and check you on your 6th visit.
Yeah.
And compare everything, the 1st visit to the 6th visit. We have our latissimus dorsi transverse lift from the ribs. Okay. So the concept of lifting and doing soft tissue on the latissimus dorsi is that your latissimus dorsi muscle has to be extensible. It has to be able to lengthen in order for you to achieve full flexion or even full coronal abduction. Okay? So the latissimus dorsi is, we learn it as a superficial back muscle, right? But really it's an upper extremity muscle. How is it an upper extremity muscle? Where does it attach? It attaches where? In the humerus. Okay? So if it attaches at the humerus, what does that mean? It's a shoulder muscle, but we learn it as a superficial back muscle. Okay? So if we neglect assessing, so we get patients who come in and say, oh man, this is as far as I can go. This is as far as I can get. And we only look at the muscles of the GH joint, say we only look at the rotator muscles, or we only look at the scapular muscle, and we neglect to assess the latissimus dorsi, we could be neglecting to assess a huge component, a major muscle that plays a role in upper extremity overhead mobility. Okay, so who do I have as a patient? So basically, if you look in the picture, I'm kind of grabbing the latissimus dorsi and I'm lifting it from the ribs. I'm gonna compare, examination-wise, you will compare both sides. Okay. So I got my pillow for my barrier. I'm gonna come in, all right. I'm just using my hands to find her lower ribs, her mid to lower ribs. I find them, so you feel my hands on them. So she feel my hands on them. I'm gonna take my thumbs and kind of bring my index, all of my fingers closer towards my thumb. And now I have fibers of her latissimus dorsi muscle. And so these fibers of the latissimus dorsi, I'm attempting to move away from the ribs. Okay. So how am I moving away from the ribs? So as I as I squeeze them, right, those fibers, as I squeeze them, they are moving away from the ribs. So just imagine the fibers becoming more concave on the ribs. The fibers that I'm grabbing are becoming more concave on the ribs. So say this right here is these fingers are my ribs. I need somebody else's fingers. Come here, Seth. These fingers are my ribs. This is Seth's latissimus dorsi. I grab it, squeeze it like that, and if you can see, is now the fibers are being lifted away from the ribs. Can y'all see that? So I let it go, then now they're going back down on the ribs. But I squeeze and try to pick them up and lift them away from the ribs. So now this on the surface becomes more concave. If that makes sense, everyone? Okay, so that's the latissimus dorsi lift, all right? And I can work my way up. I'm gonna come work my way up, more proximal to the shoulder, which I'm gonna end up getting some. So you see that? So the outer surface being convex and underneath being concave. Sometimes they refer to this as muscle bending as well. Okay. Everyone see that? And I can get here and work with it. Move it up and down. Dr. McClure, you use that technique a lot?
I use it some, yeah.
Okay. So I'll let Dr. McClure demonstrate how she does it as well, if you don't mind, Dr. McClure. I know Dr. McClure uses that one a lot.
So again, depending on my patient, right, I'm using my clinical judgment, if you will. So I might start here where the muscle is slack, see if I can find it, okay? And then come on up here, I can get her into as much tension as I feel like I need to get. Some patients are gonna be able to go all the way overhead, but a lot of your shoulder patients are restricted, right? That's why they're coming to see you. They can't get their arm up overhead. So I may come in here and I may make sure your patient can breathe, but I may use something to get them overhead, but support it a little bit, okay? We have one more pillow.
And notice I have the patient like that in the picture with the arm over the head, so don't forget that component. I forgot to incorporate that component.
Right, so I usually start with them slacked, but once I determine how much mobility or restriction we have and how much shoulder motion they can tolerate, I'll treat them up, okay? So I might even get her up here. Is that okay? She can still breathe. Her arm is up here. She's supported. And now I can, and I had you toward me a little bit. My arms aren't quite as long. Thank you. Okay, and I can come down here and I can find and I'll just work on the section of the muscle that I can get. Trying to lift away from the ribs. I may slide this up a little bit. Okay. And then I may pair that with some other techniques to just really release that lat. So I'm working on extensibility, getting all that myofascia around the lat, moving, and then trying to lift it away from the rib. Any question about that? Okay. And that with all those techniques, right? You can start, I forget what we were doing last week, maybe the pec. Same thing with the pec, right? They were laying on the back and I showed some of you, so some of your patients may not be able to get here. That's why they're coming to see you, so you may have to support them in a little bit more slack position where you feel like you can get a hold of that pec, get up underneath it, and then as you make some improvement there, you gradually work their arm back into more range and more tension in the muscle, okay? All right.
You're gonna see that all the time, shoulder pain. Within your first year of practice, if you work outpatient orthopedic, you're probably gonna be seeing so many shoulder pain cases that you're gonna see a variety of causes of shoulder pain. So it may be frozen shoulder, it may be rotator cuff pathology, it may be rotator cuff repair, it may be total shoulder arthroplasty, it could be bicipital tendonitis, or it could be shoulder tendonitis. Shoulder tendonitis is when it's bicipital tendonitis and rotator cuff tendonitis. So you're gonna see the whole gamut probably within your first year if you decide to go outpatient orthopedics. Okay? So now I'm thinking supporting interventions.
Can I make one more comment on that, Kenny?
Go ahead.
Hey, how could you if you were not sure you were on the lat, what could you do to confirm that? We could have them do a submaximal contraction. Would you have to do internal rotation or external rotation, or what would you have them do? Okay, so you can have them do a little bit of a maximal contraction of the motion that whatever muscle it is you're doing is to, if you're not sure, if you're like, I can't tell if this is lats or just the erector, well, do something that the lats do that the erector doesn't, see if you feel it. Okay? And that works with a lot of your techniques.
It sure does. So now, all right. So let's go back. So we done soft tissue work on the lats. Person can't get full flexion, can't get full coronal abduction. We keeping it simple right now because everything's gonna build on. What joint mobile you gonna follow that technique with? What joint mobilization at the glenohumeral joint? What you say? Inferior glide. That's one that you could justify because the head of the humerus have to glide inferiorly with coronal or flexion, right? With coronal abduction or flexion. Now, what mobilization could you perform at the scapula? Upper rotation mobilization, or you could do cephalic mobilization, either or, which is good. All right, I'm just giving you how to think, how you got to be thinking because it's a complex. So don't forget, you got the sternoclavicular articulation. All right, you got the acromioclavicular articulation. You got 4 different joint complexes. That's why you always hear me say shoulder joint complex. Whenever you hear me say complex, that means it's more than one articulation making up that joint complex. All right. Now, so we talked about some joint molds. You got to be able to do that in the practical, right? What can I do for supporting intervention for therapeutic exercise with her in this position? I want you to start right here. You're gonna move this weight as far overhead as you can. If it's too heavy, you let me know. But I want gravity to end up acting down on that weight to elongate the latissimus dorsi. So it's gonna be strengthening eccentrically. All right, come back down. All right, do that about 5 times. So that would be a supporting intervention. How would I teach her to stretch that muscle? How could I teach her to stretch that muscle?
Get up against the wall.
So yeah, she can get up against the wall. How would you do that? How would you show her how to do that?
Get a towel, put your hand flat against the wall and lean into it.
So go quadruped for me. So what side do you work on? The left side, right? Go into like a child pose. There we go. And now what you're gonna do is reach over this way. There we go. Y'all see that? Reach over there. And so now we stretching out, elongating the latissimus dorsi on the side that we worked it. So this is a good stretch that you all can have the patient do to stretch the latissimus dorsi muscle. All right, go ahead, sit up. So remember, this course also incorporates therapeutic exercise. That's why I'm taking time going over supported interventions, so that when you come to the practical, you're not cold turkey. But there are many more things you can do. So if you go to the slides that were posted, remember I told you to go to all of those slides and write on each slide when would you do this exercise? You know, after wet soft tissue technique, after wet joint mold technique, and then write out your rationale. Would you use it for eccentric strengthening, or would you use it for concentric strengthening, or both? In whatever case, write it down, go through those. That's gonna help you in your lab practical. Most of those exercises are straight from Dutton and Kajner and Colby.
Dr. Carter?
Yes, sir.
What does concentric strengthening look like?
That's a great question, Emery, because this is what you should have learned in therapeutic exercise. So I gotta go reteach this, right? All right. Let's go. Let's hope you get this.
Very painful.
All right. Now, concentric strengthening is when the muscle fibers are shortening. So we're strengthening muscle fibers are shortening. So this is my biceps brachii, right? As I do a biceps curl, I'm now concentrically strengthening my biceps brachii muscle. Concentrically. As I lower this slowly, I'm eccentrically strengthening my biceps brachii because they are lengthening, but I gotta control this extension. So I'm not able to control this if my biceps brachii are weak eccentrically. I come back and curl, that is concentric strengthening of the biceps brachii muscle. Okay, you got that? So concentric strengthening is shortening of the muscles. Eccentric strengthening is elongation of the muscle. Eccentric strengthening focuses on controlled mobility. So we can't function and perform any type of skill without controlled mobility. All right. So another example, because I like to give more than one example to try to be a good teacher. I try to do that to try to be a good teacher, right? That's what I try to do. Now, this is the answer every question because I'm reteaching stuff we should know from previous semesters, but I don't mind doing that though. So now I'm going to sit down. I gotta control my sitting down so I just don't plop down, right? How are my quadriceps contracting? Eccentrically. They are elongated because they gotta control my sitting so that I just don't plop down, all right? If I go stand up, how are my quadricep muscles contracting? Concentrically, all right? So they gotta have concentric strength for me to stand. They gotta have eccentric strength for me to control my sitting. This is a teachable moment. So now you're gonna teach me, you're gonna run me through hamstring strengthening in a prone position for concentric strengthening and eccentric strengthening.
Okay.
Because I can't have you going through National Physical Therapy exam not knowing this. Going
Now you lay on your stomach. Now your hamstrings must concentrically contract to flex your knee and eccentrically contract to straighten it back out. So let's try that one more time.
So what are you gonna have me to do? What are you gonna instruct me to do? Because you just did it for me.
Can I have you bend your left knee as high as you can? Try and get as close as you can to your butt. Okay. Now can you slowly lower it back down to the table?
Which one is eccentric? Which one is concentric?
When you bend your knee back up, this is concentric.
Good job, Emery.
And when you lower it back down, it's eccentric.
Good job, Emery. You got it, Emery. So how would you make me contract my hamstring isometrically? So I'm giving you some extra stuff now. This is called a hamstring set.
Hold this position, Dr. Carter. And don't let me move you. That was good. So it'd be like that.
Okay. So good. You get that. So that's one way. I say I'm gonna go prone just to see what you come up with. So that's good. You can create the isometric resistance against your hold, right? And you could isometrically work the muscle throughout a range. So you can work it at 90 degrees of flexion. You work it at 20 degrees of flexion. You can work it at whatever range you choose. Now another way you could do it is have the person supine, knees flex, slightly flex, and have them to press their heel into the mat for about 5 to 10 seconds and then relax. So when they press their heel into the mat, that's a hamstring set, an isometric contraction of the hamstring muscle. All right. Same thing, quad set. Quad set, they just press the back of the knee into the mat, holding it for a while. Okay? So isometrically, the muscle does not shorten nor lengthen, but it's contracting in one position. All right? In a particular range of wherever you set the joint. So now go back and review, go back and read up on this. Well, you can pull out your therapeutic exercise book. Concentric contraction, eccentric contraction, isometric contraction. So you have to have a strong command of those. So this is good. Emory asked that question because does that apply to this class? Yes. You got to be able to explain those on your lab practical. You got to be able to explain how you have the muscle contraction with your supporting intervention. So when Emory asked that question, that's why I took time out to go over that content, because you got to be able to explain that for every muscle. All right. So your lab practical, you got to have a strong command of muscle action and how they're contracting concentrically, eccentrically, isometrically. Now, if you don't have a strong command of muscle actions, you toasted. You're gonna about to perform a pectoralis major leg test and stretch. All right, put your legs up for me. There we go. So what does the pectoralis major do? What's this muscle action? So horizontal adduction, coronal adduction, internal rotation, right? Okay. So what I'm going to do to assess the length and also stretch the muscle, I'm going to get him in coronal abduction, his joint also in external rotation, and then, all right, I'm gonna internally rotate him some more and get him into abduction and also extension. All right. So right now I have him in coronal abduction, also GH joint extension. Okay. Do you feel? So now, if you come look, you can see that his pectoralis major has lengthened. All right, it's in a lengthened position. Now, if I bring his GH joint more so in internal rotation, it is still lengthened with coronal abduction, right? So what? And I'm gonna add up a little bit more. How can I stretch his muscle a little bit more at this point? What can I add to the GH joint? So I have him in coronal abduction. I have him in extension. And so externally rotate. So I'm gonna externally rotate him. When I took you to external rotation, did you feel a greater stretch? So he should have felt a greater stretch on his pectoralis major muscle. Should I slide off this a little more? Yeah, you come a little bit more. Good job. So he asked me, should he slide off the table a little more? Yes, I could actually have his arm come a little bit more, hanging off the table. Yeah, so he felt limited. So that's good feedback from my patient. So I could actually take him into more extension, like so, and more abduction. I can bring him out of external rotation, take him up into more coronal abduction. If I want to stretch the fibers even more, then I can add external rotation. So you see how I'm adding external rotation to that? And he should feel a greater stretch. Okay. So I'm using this as assessment and treatment. With assessment, I'm assessing I'm assessing the resistance that I feel against going into the motions that stretch the muscle. That's assessment. And then for treatment, I'm gonna take him as far as I can take him into the plastic range and hold that stretch. All right. Now, I can even turn this into a hold relax or contract relax. So I can get him right here, come right here, okay? Now hold this position and don't let me move you. Hold it, hold, 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 and relax. So really I'm trying to take them into extension, more abduction, and external rotation. So after he holds that, then I could take him into a greater stretch. After I get him out the hole, greater stretch, This is hold relaxed technique. Take them to the stretch for about 30 seconds. And then I can repeat the process and try to get greater range of motion. Okay. So if there's someone has a tight pectoralis major muscle, then you can do a length test and then also turn it into a treatment. Okay. Now I can also contact the sternal and upper rib margins, moving the humerus into external rotation, right? So sternal right here, upper rib margins like so. I'm gonna raise them up some. Right here like so. So I just palpate right here at the sternum. So I'm just adjacent to the sternum and ribs. I can maintain external rotation and take him into more abduction, or I can bring him out of external rotation, add more abduction and extension, and then add external rotation. You got options there. It says glenohumeral extension is engaged, then external rotation. All right, so what that would look like. Coronal abduction, extension, then external rotation. Did you feel a greater stretch with each of those components? So
I don't know if I felt this
So-
a lot on the pec.
coronal abduction, I'm gonna add extension, then I'm gonna add external rotation. But the more coronal abduction I add, extension, the greater the stretch you should feel. Okay. So, all right, that's that one. This is utilized to elongate the anterior and posterior structures of the upper thoracic area. And so we're moving from a medial to a lateral direction. I typically do this one with gloves on, using some free up. So I come right here. So my hands, I typically start this one, and with my hand that's on the posterior aspect, I start around T1, C7, T1 junction, and I bring my hands that are on the anterior aspect of the shoulder, just below the neck. And basically what I'm doing is just gliding, just a glide of my hands across those aspects, like so. So moving from medial to lateral. And they just call this lateral telescoping. So a good preparatory technique when working in the shoulder before going to other specific techniques. You use this from a lot, Dr. McClure?
I use it a fair amount.
Yeah. So that's a technique that you can use as well. Very gentle technique, gets the patients comfortable with your hands. Is not very aggressive. So a good gentle technique that you can start out with anybody coming with any kind of shoulder problems. It says seated at the head of the table at approximately a 45-degree angle to the patient. So this movement is looking like this. So I'm standing, but you can do this sitting down too if you would like to. All right, anything painful, discomfort about that? This technique is anterior lateral elongation, fascial elongation of the superficial fascia of the anterior lateral trunk. And so this is going to elongate those soft tissue structures along the anterior lateral aspect. One significantly being the serratus anterior muscle that could get that could be limited as well in mobility. And so this is a good one to help stretch that muscle as well. This also captures latissimus dorsi as well, but more so on the anterior lateral fascial elongation. So I'm coming right here like so. So this one, I will have the patient shirt up some. and then I'm gonna get him into a flex position like so. And now this is my mobilizing hand. So I'm gonna apply a traction force through the arm like so, okay? And my hand's gonna be starting at approximately the xiphoid process area. So coming right, so about right here, xiphoid process, okay? I'm gonna be working diagonally to the opposite ASIS. So right here, my hand is elongating and my force is like so. So you feel that, Tavian? Okay. So my force is going in a diagonal manner to his opposite ASIS like this as I apply the traction. Repeat that again. So I'm applying the traction, and then do you feel the stretch up in there when I do that? Okay. So follow to the collar direction, laterally or in a straight horizontal plane as well. So I also had an option, in addition to my diagonal movement, I also had the option of just going as I apply the traction through the shoulder. I also had the option of just going straight as well. Okay, or I could go diagonal this way. Go right here. So my patient reported that he feels this one better. My hand is going like so in this direction. And so he probably could feel that one better because when I bias, I did with my tractioning technique. I'm tractioning him in more abduction, right? As I provide a force going that way. So that makes sense why he probably felt that one better. So that's the anterior lateral fascia elongation of the superficial fascia. So let's go back. Okay. Jessica, when would you do something like this? She said with joint capsule restriction. I said, okay, rationale that out for me. Because this is what you're gonna have to do on a practical. So I can buy that, I'll take it, but now you gotta rationale it out.
So if I don't say joint capsule restriction and I say tightness with coronal abduction, would that be the rationale to why I would do this?
So you're gonna say the patient, you would use this technique when a person has limited coronal abduction. Yes, you could say that. Now you gotta rationale it out. Okay, all right, good. Now you gotta be able to think forward and backwards throughout your entire practical. You gotta be able to go from supported interventions to joint mold to soft tissue. You gotta be able to go soft tissue, joint mold, and supported interventions. You gotta be able to go back and forth. So since she jumped and said joint capsule, I didn't stop her. I don't want to stifle thinking. Now, which portion of the joint capsule are you stretching in addition to the pectoralis major muscle? Which way is the head of the humerus gliding?
Anteriorly.
So which portion of the joint capsule is going to be stretched based on the concave convex rule? Anteriorly. All right. So now this is why you got to be able to go back and forth, right? So you lengthen, you did the pectoralis major stretch. All right. Now one of the best, he's limited with horizontal abduction. We're gonna say he's limited with horizontal abduction. So now, what joint mold do you want to come back and do? Following that technique to get him to be able to perform horizontal abduction. Anterior glide. So that's why when you said the joint capsule, you said I would do this for the joint capsule. Now you got to be able to rationale it. So probably the best approach for your practical, right? That's why I'm going through this, is to approach it like what Tavian said. Tavian started with the soft tissue. All right. So let's go back to what Tavian said. So we discussed horizontal abduction. All right. So let's go back to what Tavian said, because what you said, joint capsule, is not wrong, but you just gotta be well versed in how to verbalize that. So you say you perform an inferior glide, right? Well, that's not wrong if you're trying to improve what? Coronal abduction. So if you're using that technique to improve coronal abduction, then you come back and say, okay, I'm gonna follow that technique with an inferior glide because coronal abduction is limited. Perform extension, shoulder extension. Does it lengthen or does it shorten? Pectoralis major muscle actions. What are they? What you say, Kira? I see you checking somebody out, Kira. That's fact check. Horizontal adduction, medial rotation, coronal adduction, clavicular head, flexion. Could it possibly limit shoulder extension? Yes. So when we do extension, it's elongating the clavicular head of the pectoralis major. So make sure you go through that score better as an app and command that, those muscle actions. So now I'm coming back to Jacayla. Jacayla. Yes or no? This is what I want to know. Yes or no? Think about this now. I'm about to hit you with something you got to think about. I'm having limitation with shoulder extension. I can't get back there, shoulder extension. Could the pectoralis major potentially be a problem?
Yes,
Why do you say yes?
because it's a antagonistic muscle to shoulder extension.
Good job.
So it stretches.
Good job, Jacayla. I was seeing if you're gonna fold under pressure. Now I'm gonna ask you, if you were to do this technique and he has a problem with extension, what joint mode would you follow up with to help with him with proving extension at the GH joint?
And the anterior glide,
Good job. Why?
because during extension, the humeral head glides anterior.
Good job. What's gonna be your supporting intervention?
So we have the patient either supine or standing, either one, with a weight, just performing.
Would you have him supine or prone?
Prone.
Prone would be a better position. And him performing shoulder extension. Good job. So you would have just, if you explained all of that very well, you just made 100 on your practical. Elongation of superficial fascia. You just did this technique. Seb, what could be a potential impairment as to why you would do this technique?
You're unable to fully flex the shoulder.
Okay, that's an impairment. Limited flexion of the shoulder. All right. So you could do this technique, right, to help with improving that. This could be a potential problem. You can assess it, treat it. Now, what joint mode are you gonna follow with after you do this for that impairment?
Do a posterior glide of the glenohumeral joint.
Why?
Because it's required for flexion.
Okay, necessary for flexion. Good job. What's gonna be your supporting intervention, Sel?
I would probably have them with a dumbbell in their hand, lifting forward up in a flexion motion with their shoulder.
Okay, what else could you do?
If I wanted to do a stretch, I could have them laying supine with the weight above their head to help the weight lower them down into a further stretch.
Okay, good. So this is how you have to be thinking. So I like to teach this how you have to be thinking for the practical. So therefore you all are not thrown off by the time you get to the practical, you know how you need to be practicing. So we're gonna move on to the next group of slides. So we're gonna do the outward roll of the radius on the order. The outward roll of the radius on the order is a connective tissue technique. It's a joint play. It's considered a joint play, but it's stressing connective tissue extensibility. And the connective tissue we're talking about the distal interosseous. So you know we got the interosseous fiber structures in between the connecting the radius and the ulnus. So go ahead and lie down for me. I'm gonna do this one with the patient supine. So this is a good technique if the patient has limitations with forearm pronation and supination. Okay? So they have limitations with forearm pronation and supination. This is a soft tissue technique that you can utilize. All right. Now it's also a component motion for the elbow, for elbow flexion. But in particularly, we want to use this one for forearm pronation and supination. All right. My right thumb is in contact with his radius. All right, along with my web space and my index finger. My left thumb is in contact with his distal ulnar along with my web space and my index finger. So anteriorly, my thumb is in contact with the ulnar anteriorly, my left arm, and my right thumb is in contact anteriorly with the radius. Does everybody see that? Okay, so this is an outward roll of the radius on the ulnar. So what I'm doing, my left thumb that's in contact with the ulnar along with my web space and index finger, I'm stabilizing the ulnar. I'm not moving it at all. And so what I'm doing is exactly what it says, is an outward roll of the radius on the ulnar. And so what I'm doing, I'm moving the radius and rolling it outward. Do you feel that, Tabian?
I do.
And then I relax off of that. And so my mobilizing hand is my right hand. And so this is the motion I'm making, like this. Outward rolling of the radius. And so if I'm making this motion like this, so my web space and my index finger is mobilizing as well. Okay, so you can say that my web space and my index finger is moving the radius, I guess, with the outward roll, moving it actually in that direction, and my thumb is moving it outward, like so. Okay, and I can hold that there for a certain amount of time and then ease off of it and do the same thing again. Okay, so that motion, that outward roll of the radius occurs with supination. All right, but you can use it for supination and pronation because it's working on the extensibility of the connective tissue, the interosseous membrane connecting the radius on the ulna. So now we've done that, right? So say we want to improve supination. What's a technique? What's a technique that we can use to improve a joint mold technique that we can come back and follow with this connective tissue technique?
Yeah, this is a joint play, pronation, supination.
Okay, you could do that. So let's do that. If it's on the PowerPoint. So I'm gonna have him like so. So I'm gonna go back over this technique because many students mess up on this technique. All right, so I'm doing a posterior glide of the radius on the humerus, right? Of the radial head on the humerus. The best way to do this technique I place him in slight elbow flexion. Thank you, Dr. McClure. If you want to remember the line of force, is to come across the body. So I'm gonna come here. He's stabilized against the table, but I'm still gonna put my hand there for stabilization. And now, I can let him just relax right there. I'm trying to maintain slight flexion for me. And now I'm coming across the body, and now I know my line of force is where I need it to be, posterior in that direction, because we don't want the joints coming in contact with each other. Does everybody see this? So that's the posterior glide of the radial head on the humerus. Now you can do it this way as well. You can do it in a seated position, like so. So, but you're gonna have to make sure that you're, this could be more uncomfortable for the patient, but it can be done this way. So you can use your index, middle finger, and ring finger to grasp the anterior aspect of the proximal radius, and then move your hands line of force. See, my line of force is in directed with my forearm. So I'm moving in the radial head posteriorly. So make sure you go back and pay attention to those slides. So yes, that is a joint play for pronation and supination. Good, it is. Way to reference your slides, because that's what Dr. McClure and I are going to be doing. We have this up in front of us. So you can use that technique as a joint mold technique. And now what are you going to do for your supporting intervention in the body? So we've done a soft tissue for pronation and supination. We've done a joint play. We've done a joint play for posterior glide of the humeral radial joint. And now you got to follow with a supporting intervention. What are you going to have them do? And you can just leave them in this position. So now, hold this for me, Tavian, like so. All right. So you're gonna turn it all the way down like that, and just come all the way back, turning it up like so. Just do that for me for a while. Okay, this is supporting intervention, working on pronation and supination. All right, now come right here. So what muscles are performing supination? Good job. The supinator and biceps brachii. They are contracting how when he goes in supination? How they contracting when he goes into pronation? What muscles are contracting eccentrically for pronation? Pronator teres, and what's the other one? Pronator quadratus. Good job. So you got pronator teres and pronator quadratus. And so as he goes into pronation, how are they contracting? Concentrically. Good job. How are the biceps brachii contracting? Eccentrically. Good. Good job, you all. Now y'all catching on. Yes.
Was it the hook?
Yeah, that's what I was thinking about. So for supination, the volar glide of the ulnar, the triquetral menisco technique. So I come right here, I stabilize the radius. I stabilize the radius with my thumb and my other fingers of my right hand, and then my index fingers are blocking the triquetrum and pisiform. And as they are blocking with my thumb, I'm performing a volar glide of the ulnar. Y'all see that? You feel that? Maybe this is what I'm thinking about. All right, next one.
The short head is going to come up and attach to the coracoid process. All right. So I can bring my patient here. I'm going to take them to a loose pack position of the glenohumeral joint. Okay. I may need to use my knee to help me maintain this. I do. I'm a bit of a weakling. It helps me to prop my patient here on my knee, okay? Now I'm gonna come in here, I'm gonna find that coracoid with my thumb, and I'm gonna stabilize. Sometimes that's a tender area, so be easy as you go in and find it, okay? Now from here, this is a multi-stage technique, okay? So I've gotta get myself in a position that I can keep him supported, loose packed, stabilize the coracoid, and come back into and I already feel that coracoid moving. So right about here, I feel his coracoid, even though he's got more external rotation, I feel his coracoid start to move on me right about here. Can you feel that too, Tavian? Okay, so this is where I'm gonna do the technique. I'm gonna take him to where I feel the coracoid start to move, all right? And then, so that's kind of step one. If you see there's 2 slides on there, one is for step 1, and I can even feel around here, I can feel that bicep tendon right here, okay? It's right there attached to the coracoid. All right, so from here, now I can pronate his forearm and take him into elbow extension. He's tight. Tavian's actually got a tight short head of the bicep. You can see I'm not taking him into full extension because I feel the coracoid start to pop again, okay? Is that too nubby on your forearm? Okay. So I'm gonna hold him here for a few seconds. Okay, I think your slides say 5 to 7 seconds. Ease out of it, okay? Maintain my coracoid stabilization, pronate him, go into extension again, hold this stretch, 5 to 7 seconds. Okay, I'm gonna do that a few times. Then I'm gonna take him out of it altogether. And I can recheck, okay? Hard to see rub down, right? Check it again. And again, there's something that tipped you off with all these techniques. There was something that drew you to want to check it before you treated it. So if it was he's lacking elbow extension and I think he's got a tight biceps, well, then after I do this technique, what am I going to go recheck? Elbow extension, right? I want to see, did it make a difference? Did it not? Do I need to look elsewhere? Right? And then if maybe I made a little difference, but it's still tight, then my mind goes to something else, right? So maybe the joint. Maybe we need to work on the joint. So here again, coracoid. Okay, I'm going to take him into external rotation till that coracoid. There we are. Till that coracoid wants to pop. Pronate and extend right there. Okay, so that's the short head length test.
So now you have to be able to rationale as to they could be problems. So how can they be problems? Like what could be happening as to why this technique would be needed or necessary to use to improve a problem. So for example, if elbow extension is limited, right? How does this help improve elbow extension?
So it will allow for more mobility.
Okay, good. So the stretch to your biceps, to the short head of the biceps, will allow the person to go into extension. So now we got to think about this. We got to put information together. So we've already identified that if the person has a UCL repair, or even if they've had a rotator cuff repair, could this be a problem? Why? Post-op UCL repair. Y'all, somebody did a presentation on that, right? The person status post-op, what's going on? They're immobilized how? So they're immobilized in elbow flexion, right? So also maybe some internal rotation as well. But because they are immobilized, now those soft tissue structures are going to be restricted, especially if they're immobilized in flexion. So now since they're immobilized in flexion and have been immobilized, say they've been immobilized and the doctor told them to stay in that sling like this for 6 weeks. don't you think when they come out of that sling for 6 weeks, don't you think that this may be a problem? Yes, it's gonna be a problem. So now you know something that can treat that problem. So now you know they're likely gonna have some issues with getting into full elbow extension. It's gonna be problematic. But now you know a technique that can help with that, okay? So it's a long head of the biceps length test and stretch as well. It's similar, but there's some small differences. So now we got the long head of the biceps length test and stretch. So a similar procedure. Now we're gonna be elongating the long head of the biceps. So now I'm gonna stabilize the superior anterior glenoid rim. So now my stabilization is at the joint line, all right, versus me having my thumb on the core process. And I'm just coming along the joint line. So you see that? So now I'm along his joint line. So I'm gonna stabilize the superior anterior glenoid rim. I'm gonna maintain the GH joint. Scoot over a little bit for me. Maintain it in extension. So he's in extension, and I got him at about 30 to 40 degrees of coronal abduction, if y'all can see this. All right, so I'm use my thigh today, I'm rest his proximal forearm on. So now, notice his forearm is in a neutral position, okay? So what I want to do is I'm gonna move the elbow into extension, okay? So I'm moving the elbow into extension. I'm maintaining his GH joint in external rotation. So it's being maintained in external rotation. And with his elbow in extension, what I want to do to his forearm is add pronation to the forearm. And that is gonna elongate the long head of the biceps tendon. Do you feel that? Okay, so he feels that. All right. And so if I bring him out of forearm pronation, that reduces the tension of the long head of the biceps brachii. If I'm bringing him into more flexion, that reduces the stress and tension on the long head of the biceps brachii. So coronal abduction, 30 to 40 degrees, GH joint extension, extend the elbow, pronate the forearm. Okay. To add a further stretch, I can take them into more extension. You feel that better? So I took them into more extension at the GH joint. Kept the elbow extended, kept the forearm pronated. So basically I just took him into more extension so that he can feel it more. Okay. So the greater extension you take them to in GH joint, maintaining elbow extension, maintaining forearm pronation, is gonna elongate the biceps, long head of the biceps brachii more. All right. Any questions about that? So for stretching, you can stretch for 2 to 3 repetitions. Hold it 30 seconds, 60 seconds, 90 seconds, however you want to do that in your treatment progression. All right. So again, long head of the biceps brachii. If it's taut, what could it limit? Elbow extension. Okay. Could it potentially limit shoulder extension at the shoulder? Yeah, it can, because it crosses both. Okay. So it has to be able to elongate with shoulder extension. So it could limit shoulder extension as well. Okay. So now let's backtrack. All right. So we're gonna say there's a hypothetical scenario. Patient just had a UCL repair. All right. Baseball player, 16. Pitched a lot from Little League on up. At the age of 16, threw out his arm because the coach used him too much. In the sling, bend of the sling after UCL repair, they're gonna be elbow flexion, and they're gonna be limited with elbow extension, because that sling is gonna have them immobilized in flexion for quite a bit of time. So you get them out, we say elbow extension as our primary impairment, right? We do the long head of the bicep stretch, we do short head of the bicep stretch. What is gonna be your joint mode at the elbow? What would you do? So Seth said you're gonna do an anterior glide. Anterior glide of what, Seth? Okay, so he's talking about the shoulder. So he's talking about the shoulder. Okay, good. So he said extension is limited. So I didn't say which one. So he said shoulder extension, he would do an anterior glide with shoulder extension being limited after doing these techniques. Good. At the elbow joint, so say elbow extension is limited, you do these techniques, what glide are you gonna do at the elbow joint complex? So Dominique said you can do a caudal glide, caudal or wet? What are you moving on wet? Okay, so she's saying you do a caudal glide of the radius on the humerus, or you can do a posterior glide of the radius on the humerus to help improve elbow extension. All right, good. The next technique focuses on the septum between the biceps and triceps. So what it means by septum is we have fibrous connective tissue between muscles that actually, in a sense, conjoin the muscles. And so sometimes that septum can be restricted and limited as well, that fascia that's connecting those muscles to one another. So the septum between the biceps and triceps can be a beneficial technique if somebody's had trauma to this area and that area is just stowed up and tight. It could be due to a fall. It could be impacted by a fall on an outstretched arm, fall on the side of the arm, motor vehicle accident, a helmet hitting that arm, a baseball, any type of blow to this area, a traumatic event to this area. So what I'm gonna do, I'm gonna take my left thumb, so I'm gonna palpate for the septum. So I feel his triceps, and I feel the lateral head of his biceps, and I feel the lateral head of his triceps. So he should be able to feel my thumb in between each one right now. Do you feel it? So now I take my left thumb and I bridge it at the septum, just superior to the triceps, to the lateral border of triceps. And then I come with my other thumb and I get in my right thumb, and I'm gonna get it in just inferior to the lateral border of the lateral biceps. So now he should be able to feel both of my thumbs in between the septum of the triceps and the biceps. Do you feel them? Yeah, go ahead, there we go. That's good. So he said he does. So now I could do either or. I can have my inferior thumb, which is my left thumb right now, just here stabilizing, and I can mobilize the septum near the biceps away from my inferior arm, or I can stabilize with my right thumb and mobilize the septum. I have to lift this arm some, and mobilize the septum of the triceps brachii away from my superior thumb, like so. So my hands are getting sweaty now because I've been putting this hand sanitizer on them. So you might want to wash your hands so that your thumbs don't slide, and you just move away like so. Okay. He has more muscle bulk, but it's kind of good that he has the muscle bulk because I was able to identify the septum probably easier. But the technique will be easier to perform on somebody with less muscle bulk, but it may be easier to identify the septum on someone with more muscle bulk. Okay. But that's examination portion, and also you can turn around and use it for intervention and just increase the force and time of application. So if I want to do it for an intervention, I come back, locate the septum, I'm in between the septum, increase the force and time of application of holding that stretch. Okay. All right. So this can likely help with this. If distal, the more closer to the elbow, it can help with elbow mobility. The septum is easier to palpate the closer it is to the elbow. The more we move away from the elbow, the more difficult it becomes to find it. So it's more prominent, the septum is more prominent closer to the elbow. All right.
I probably use that most on people who've been dealing like long-term lateral epicondylitis, or something that they've just been struggling with something at the elbow for a very long time, and sometimes they'll start to see some issues in there too. It's probably one I use the most.
Oh yeah, now that's a good one for lateral epicondylitis, because with lateral epicondylitis, you'll find that many of them also have pain in the distal tricep as well, closer to the elbow. All right, the next one is extensor and flexor mechanism of the proximal forearm. It's a soft tissue extensibility stretch of the connective tissues in the cubital triangle. So the concept of this one is gonna reduce adhesions and adhesions of fascia that is near the proximal aspect of the elbow. So what I'm going to do, I'm going to manually perform the extensor tendon excursion and flexor tendon excursion of the extensor and flexor mechanism of the forearm. So I'm going to come here like so. So this being extensor mechanism right here. This being flexor mechanism, right? And I get in between those and basically I'm just pulling apart. Do you feel that, Tavian? You're stretching those apart. Move them away from each other. So I'm moving those mechanisms away from each other and trying to maintain that without my thumb sliding. There we go. I got a better grip now. So now my thumbs are not sliding. So I'm moving the extensor mechanism, flexor mechanism of the forearm, wrist away from each other. So you can use that as evaluation, and you can also use that as an intervention. So concept, muscle adherence to fascia restricts length of the muscle. And again, this would be one that'll be good to use when somebody has been in a sling for a prolonged period of time. So elbow has been flexed for a prolonged period of time. They haven't been moving the forearm, neither in pronation or supination. So they've been fixed in a neutral position. And so now that fascia and also the wrist extensors and wrist flexors are likely gonna be stiff proximally. And this is a technique that could be beneficial.